I was very pleased with the invitation to come here. I'm very honoured by it. Although I think that talking about guidelines is always a topic that includes the risk of being quite boring. So I considered if I should do some of the John Cleese silly walks just to keep you awake. And I know we'll have a thumbs up over here, but I will disappoint you on that. But I hope that you will stay with me. Now, the task was to talk about the ESCMID guidelines, and the ESCMID guidelines were set under the auspices of ESCMID in the European Fungal Infection Study Group, and the task was to set out guidelines that were comprehensive, so that they included diagnostics, but also all the different kinds of Candida infections. So these are all the groups, work items that were to be included in the guidelines. So that's diagnostics. It's the ICU population and also the other immunocompromised patients outside hematology. Then it's the pediatric patient, the intensive care of the pediatrics, the hemonc, and HIV and AIDS. So that's quite a big topic for 30 minutes, particularly because I was also asked to give my personal perspective on this in the end. Now, the EFIS study group was the group that initiated these guidelines. The authors were picked from this study group under ESCMID, but also other societies with interest in this field were invited. So that's the EORTC, the EBMT, the Intensive Care Society, and the Mycology Society. So experts from these different groups were invited and were allocated to the different groups here depending on their expertise. And in each group there were 2 coordinators appointed that were responsible for driving their field forward. And not all participated equally eagerly, I can say, but so it was quite a task for the people that had to manage these groups. Now, within every guideline, there will be recommendations if you should use or shouldn't use something, and that will be based on evidence. And for these set of guidelines, the recommendation system that was used is summarized here. So the strength of recommendation were graded either to be that ESCMID strongly supported a recommendation for use. Let's see if I can find out this out here. A moderate support for use, a marginally support for use, or a grade D that was a support against use, so don't do it. So that's kind of a traffic light. Now that recommendation were based on grading of or evaluation of the different literature and studies that were done in the different areas. So the quality of evidence was graded into level 1 to 3. So level 1 was at least one properly designed randomized control trial. Level 3 were expert opinion, so that's based on your personal experience, on case, descriptive case studies, etc. And level 2 was in between. So you go actually from very solid evidence to gut feeling, and then you have a big group in the middle. Now, for grading biomarkers, you couldn't exactly use these two systems. So that was moderated a bit, so that the strength of recommendation were based on the accuracy of the test, so that there was a test was highly recommended if the technique was accurate in more than 17% of the cases, and accuracy is the number of true positives and true negatives, so that's correct results in proportion of the total number of results you have. Then the test could be recommended if it was more than half of the test results that were okay, and it was not recommended if it was less than half of the cases. And then there was no recommendation if there were no data. And of course, you don't have controlled randomized trials, for instance, on if you should do a blood culture. You don't have trials where half of the patients have a blood culture and the other half haven't, so you can't have controlled randomized trials here. So the level of evidence were graded with a level 1 if it was a properly designed prospective multi-center cross-sectional cohort study. Level 2 were prospective single-center studies or retrospective multi-center study or case control. And level 3 were again back to opinions of respective authorities or gut feeling. Now with that, let's start out with the diagnostics and how what the recommendations were for diagnosing the invasive candidiasis diseases. So you have candidemia up here in the top, you have invasive candidiasis, so that's, for instance, infection in the peritoneal cavity, and finally you have chronic disseminated candidiasis, so that's hepatosplenic candidiasis. And for all these three invasive candidiasis, you can see that blood culture were regarded as essential investigation, and also that for the invasive forms, that culture of tissue and histopathology were regarded as essential investigation. That wasn't really reasonable to try to grade the recommendation here, but that's simply something you have to do also to have a species identification and to be able to do a susceptibility test. Then you have the biomarkers, and you will see that beta-D-glucan is recommended with a level 2 evidence for all three presentations of invasive candidiasis, and that mannan antigen and antibody is recommended here for candidemia and for the chronic disseminated candidiasis. It didn't get a recommendation up here because of lack of data at the time where the guidelines were set. It's not necessarily that the Candida mannan test is less good than the beta-D-glucan, that there has been studies afterwards. So I would probably guess that in an update it would be graded like the beta-D-glucan. And then importantly, there were no recommendations for PCR or for other antibody tests, and that was due to lack of data. Now, there were some comments associated with these recommendations, and that was that for blood culture, it's important that you ensure a sufficient volume when you culture, because that's associated with the sensitivity, and also that you should use the mycosis bottle with the medium that is specially designed to support fungal growth and to inhibit growth of bacteria. And that was based on two observations. One was that for the Bactec system, it has been demonstrated that glabrata grows quite poorly in the aerobic and anaerobic bottles. That has been shown in a study by Horwath years back, where they inoculated blood culture bottles with donor blood and a fixed number of CFU of each of the Candida cells, and showed that glabrata didn't grow as well. But it's also been shown in several epidemiological studies that showed that centres using the Bactec system had significantly lower rates of Candida glabrata. And we have also shown that that is true even if you stratify it by age, because that could be a confounding factor, because we know that glabrata is more common in the elderly population. But even if you stratify for age, you also see that centres using the Bactec system detects fewer glabrata. But you also have to use it actually for if you use the Bactec system. And that is because in the Bactec system, you fail to detect candidemia if you also have a concurrent bacteremia. That, we have shown it in a clinical setting where we see far fewer polymicrobial infections at centres using the Bactec system, and subsequently has also been shown by inoculating blood culture bottles. And I mean, we know from clinical practice in the lab that fungi grow less well if there's also bacteria on the plate. Now, for the mannan antigen and antibody test, the performance rates were summarized, and it's important to realize that it's Candida specific, in contrast to the beta-D-glucan test that also, as we heard this morning, detect pneumocystis and aspergilli. But it's also noted that it performed apparently quite well in a small case series of chronic disseminated candidiasis, where it picked up most of the cases and did that in a few weeks, 2 weeks before the culture became positive. And finally, for the beta-D-glucan test, it was recommended that you take 2 tests per week. And that should, of course, be aware that it could be something else than Candida. Now, there were also recommendations for tissue handling, and most of this is well known. But one I think I want to highlight here is the use of optical brighteners for microscopy, because it increases the speed. When you do your microscopy, you can much more quickly see if there's fungal elements in your specimen, and also the sensitivity. And also that when you go for culture, that you should use a fungal selective media. And I've just taken an example of a Candida glabrata and a Stenotrophomonas maltophilia that was mixed and seeded out on a Sabro agar, chromogenic agar, and a Danish blood agar that's used for in most bacteriology labs. And you can see here that on the selective agars you only see the growth of the Candida glabrata, but over here you only see the gram-negative rod. That, of course, also means that either the lab should always use a fungal selective media on all samples, and that would mean they would probably have to double their number of incubators, or that you, as clinicians, have to notify your lab whenever you suspect a fungal infection so that the lab can be aware of that and include fungal selective agars media. Now, they were also given recommendations on antifungal susceptibility testing. And I guess it's not a big surprise that reference methods were recommended, but also that you could use validated commercial tests provided that your test results mirror those of the reference method. And it was highlighted that expertise and cautious evaluation are required. Now, why this comment on that you provided that the test result mirror that of the reference method? Well, that's because when you use a different test approach than the reference methods that are microdilution tests, then you don't necessarily have exactly the same results. If you look at this histogram, then I've depicted MRCs for Candida glabrata and caspofungin, here by e-test, here, and by the CLSI methodology. And even though the e-test is actually standardized against the CLSI methodology, you can easily see here that the MIC is on the average moved 2 steps to the right. So you have on the average an MIC that's 2 steps higher than the result by CLSI. And I've also shown the breakpoint, the CLSI breakpoint for susceptibility, that's here with the red one, the green one, and for resistance, that's the red one here. So you see, even though these breakpoints very clearly define the normal and wild-type Candida glabrata population, that will cut right through the MIC distribution for glabrata, meaning that you will misclassify a third of your glabrata isolates as non-susceptible if you blindly adopt the CLSI breakpoint on this data set. So you have to be sure that you have to, in your own laboratory, if you use the test, because there's also some variation from laboratory to laboratory, because it's a subjective reading. So you have to take your test results and do a histogram and see that mirrors the reference methodology from where you want to take your breakpoints. Does that make sense? Then please nod if you're not absolutely in deep sleep. Okay. We also tried to give some guidelines on when we should do susceptibility testing, and that was recommended to be done for patients with blood and deep-seated infection. Also for superficial infection if you wanted to treat, if there were failure or relapse, and if you decided to do surveillance cultures and the patients had been antifungal agent exposed, then you should probably also do the susceptibility testing. And finally, you should do it for epidemiological reasons, so that you know your local epidemiology. Now with that, let's move to the treatment guidelines. And I've decided not to talk about HIV, so I will briefly summarize the 3 guidelines, or the recommendation of the 3 guidelines for the non-neutropenic adults, the children, and the hematological setting. Now, Chris have already talked about prophylaxis, empiric, and preemptive therapy. And in the guidelines, we think they always recommend that there is a place and a role for fluconazole to be used for prophylaxis in selective settings. And that is in patients that are undergoing abdominal surgery and have recurrent gastrointestinal perforation or anastomotic leakage. Now, it's a B1 for fluconazole. You could alternatively use caspofungin. For the neonates, there's an A1 recommendation if it's a preterm baby and if you have a high local prevalence. So if you are at a center with a high prevalence of candidemia in your neonatal setting, then there would be a role for fluconazole in the preterm babies. And finally, there's a role in the bone marrow transplanted patients with neutropenia, GVHD, or a delayed neutrophil recovery. And here, of course, importantly, you should also consider if you need a coverage for mold, because then fluconazole wouldn't be your drug of choice. Now, there were lots of discussion on empiric or fever-driven approach, and it was not possible to give any specific guidelines on that because the patient group is not very well defined. But probably, if you want to use it, you should be guided on your local epidemiology. In Denmark, for instance, we have a rate of candidemia that is 10 per 100,000 population. That's like 3 times or 4 times higher than in the other Nordic countries. So we are a high endemic country, and we probably therefore use quite a lot of antifungals, not only for targeted treatment, but if you're in a low incidence country, you may not need it. Now, for the preemptive therapy, so that's the biomarker-driven approach, there were comments made for the antigen antibody test that it may be false positive if the patient is heavily colonized. Also, that you should be aware of that beta-glucan can easily be false positive in particularly the ICU setting, because there are lots of things that can give rise to a false positivity. And I think it's very important when you go into the literature and you look at the specificities that are reported, try to have a careful look at the control groups that are used, because it's typically either healthy patients or individuals, or it's patients that are far less ill and therefore have far less of these risk factors for a false positive test. And therefore, quite a number of these studies may actually overestimate the specificity of the test. Now, colonization can be used, and it can predict the species of the subsequent infection, provided that the laboratory is actually using chromogenic agar and therefore detect all the different species that could be in your colonizing sample. There was given a strong recommendation against prompting therapy based on Candida and airway samples. And finally, it was said that the compound should be selected on your local epidemiology. We have now like 50% of our invasive cases that are due to Candida albicans, and more than 30% that are Paralysis. So, of course, in a patient with symptoms and a positive Mannan test, we would never start out with fluconazole, but that's because of our local epidemiology. Now, for the targeted treatment, the echinocandins were recommended as a first choice, and I will come back to why in a little while. And then, as Chris said, CVC should be removed whenever possible, and if not, candins or amphotericin B should be used. There were recommendations about step down, and I will come back to that, and that you should monitor your patient with performing a species ID and susceptibility test and continue blood culturing until negative. Now, why was Candin chosen as the first line agent? Well, if you look at all the randomized studies that have been carried out, then I've tried to summarize the success rates here on the different studies, and I've tried to be a little pedagogical because it's difficult to look at these histograms. So in this histogram, the gray and the black columns are azoles, the orange or yellow or red are candins, and the brown ones are amphotericin B or ambisome here in the stripes. So if you look at the gray ones here and the black ones, it's always numerically poorer than the comparator. If you look at the orange, red, and yellow ones, it's always better than the comparator when it's not exactly the same kind of group. But the only study that came out with a significant difference was the Riboli study that compared enilofungin with fluconazole. But you could say there is that study, and there is a trend that azoles probably perform less well. And it wouldn't be that surprising because it's static drugs than the candins. And we all know that ambisome and amphotericin B is associated with quite a number of side effects. So if you look at toxicity, they always come out poorest. Now, after this, there's been the Dave Anders study that was a quantitative review of all the randomized studies. So they took all the individual patients, put them into one big study, and looked at what drove a successful outcome. And one of the drivers were that the initial compound was a candin, and that was significantly better overall and for Candida albicans and Paralysis specifically. Now, how about parapsilosis? Because we know that Candida parapsilosis is less susceptible in vitro to candids than the other species. But it's also an organism that has a very low virulence. It's a little bit like comparing Staph aureus with coagulase negative Staphylococcus if you compare Candida albicans and Paralysis. So in the Riboli study, there was not a significantly different outcome for Paralysis, but there were perhaps a numeric poor outcome. Here we have successful microbiology response here for Anidula fungin and for flu, numerically better for flu, and also global, numerically better for flu, which probably makes sense because the MIC to candids are higher. We've also seen that quite a number of centres that use a great amount of candids, that there's been a proportional increase here in the purple bars, two different settings of Paralysis. And also there are studies showing that breakthrough infections on patients on candids are associated with being Paralysis. So even though the overall outcome for Paralysis being treated with a candid is similar to albicans, and therefore you could jump to the conclusion, say, oh, the candids are perfect for Paralysis. I would say you don't do your patient much harm giving it a candid, but you probably can do even better. And there's no reason using a very expensive drug if you could do better with fluconazole for Paralysis. So therefore, as soon as you have your species identification for a documented infection, you should change to fluconazole if your organism is Paralysis. You should stay on candid if your organism is belonging to one of these species that have intrinsic resistance to fluconazole. And if you have one that's fluconazole susceptible isolates, then you should consider a step down to fluconazole when your patient is clinically stable. Now, in the ESCMID guidelines, it was recommended that you could do that after 10 days. And I think most people in the group felt that you could probably safely do it earlier on, but there was no hard data documented when that should be. Should that be after 3 days, 5 days, 7 days, or what? And that was the reason why the recommendation of 10 days is in the guidelines. Now, there's been very little documentation afterwards concerning when you can step down. But there is one study, the Vasquez study here, and I could just say that in Denmark we actually recommend to step down even after 3 days with the feet solidly in the thin air. But if you look at the Vasquez study here, and that was a study that set out to investigate if a step down after 5 days of treatment was safe. So they had 250 patients, and half of them almost were in the early switch group. But it's important to realize that you could only be in the early switch group provided that you were afebrile had been that for 24 hours, that you were hemodynamically stable, that you were not neutropenic, and that you had a documented clearance of your infection. So that means, of course, that these patients were less severely ill and less severely infected. Nevertheless, the outcome was then compared with the overall outcome, and independently, or if you look at end of treatment after 2 or 6 weeks, the early switch group did better, numerically better than the overall group, except numerically for Clebrata. Here there was a 58% response compared to 64% for the group that didn't switch. Independently on that group was less severely ill, and that makes sense that it's probably not a good idea to step down to fluconazole if you're infected with Clebrata because it's less susceptible. And there was also seen the greatest numeric advantage for Paralysis, which again makes sense in line with what I said before. Now, there's one concern with the recommendation and the increased use of echinocandins, and that is selection of resistance. Now, this is figures from the Danish National Surveillance Program, where we in 2000, the first 4 years here from 2004 to 7 had no candid-resistant isolates in our surveillance program at all. And then you can see that we had a rising incidence of candid-resistant isolates, and that most of these isolates are Candida glabrata here in red. Now, it's important to realise that when we have a surveillance programme ongoing, then we always only include the first isolate of the patient, because if we included several isolates, then we would screw our epidemiological data set. So that means that these isolates actually represent the time point before we have initiated our candidemia treatment, so at the point where the patient probably has received the less selective pressure of candins overall. So we could ask if this rate is actually underestimating the true prevalence of candida resistance. And indeed, we've also looked into the oral cavity of patients post-treatment and found that around 10% of the patients harbour candida-resistant treatment, isolates after candida treatment. So at least compared to what we've seen for albicans, despite the massive use of fluconazole, we have virtually no azole resistance. It seems like the Candida species are more prone to develop candida resistance. And it is a problem, particularly when it's glabrata, because it's also resistant to, or at least intermediately susceptible to fluconazole. And it's not just in Denmark. It's also been seen elsewhere for glabrata in various parts of the world, and in some centres reaching quite high figures. So that means that you should probably be cautious if you have your patient on longer-term treatment, and try to evaluate if you could step down to something else or switch after something like 3 weeks or so. I think that following these guidelines, there are definitely some areas of debate and perhaps disagreement. And I've just picked 2 issues that, from my personal point of view, for instance, are matters that could be debated. For instance, for candidemia, a stronger recommendation was given for voriconazole than for fluconazole. And that's actually not really based on solid evidence, because there are a lot more experience with the use of fluconazole for candidemia than with using voriconazole. And then you could argue, well, yes, but there's glabrata. But actually, glabrata didn't do very well in the Kuhlberg study on comparing voriconazole and amphotericin B. It was only a 50% response rate compared to 70% response in the 70s response rate for the other species. So I don't think voriconazole is a drug of choice for glabrata anyway. And it's associated with a lot more complications like interactions and side effects and various drug levels and what have we. So that's definitely a point where I disagree. Another example is, for instance, the recommendation B3. B is quite a strong recommendation for a combination of ambisone and fluconazole for 4 weeks for Candida meningitis. Now, if you look into the guidelines, there's only a single reference, and that's a case report about a premature baby that actually was multi-ill, so there are lots of other reasons for determining if the patient would recover or not. And the treatment itself were actually 2 weeks on conventional amphotericin B with flucytosine, followed by conventional amphotericin B with fluconazole for 4 days, so a total of 16 days before this kid actually had 4 weeks of ambisome and fluconazole. So, I mean, you can't base a recommendation on that kind of evidence. So that, of course, have initiated a little bit of discussion. It's not really to be very hard on the guidelines, because it is a massive work, and I also want to be very politically correct. But of course, it's impossible to do this without having some issues that may be less strongly founded, you say. So following these guidelines, there has been a revision of the SOP for how ESCMID guidelines should be developed. And I've highlighted 3 issues here. One is, which I really think is a good thing, is that there will be in the future a public consultation period on the website on any guideline before it is finally accepted. And I think that is a very good principle. We do that with the breakpoints also in UCAST, so that it's out on a global consultation. Everybody can come with their comments and review the data and their views. Also, that there will be an obligation to comply with the agree and the grade system. The grading system that is used in the Candida guidelines is not exactly the grade system. And I think it's quite confusing for the clinician that there are lots of different grading systems, and would be in the future be be practical if we use the same grading system all around. And that we appreciate that the quality of evidence has to be very rigorously evaluated. And finally, that there will be regular revision. I think that's important as well, particularly in our area that is under constant evolution. We have new biomarkers coming up, as we've heard of today also, and it's important that they become incorporated in the guidelines. And finally, there are a set of changes that will ensure that it's really guidelines that the guidelines are only produced if there is a true need. So, still in conclusion, I think one of the major advantages about these guidelines is that they provide a tool with which you can try to persuade your for instance, microbiological colleagues to use, for instance, optical brightness that really improves microscopy, to use fungal selective agars, because it's a lot more difficult to implement these things when you have a guideline saying that you should do this. And I think that's probably one of the major advantages for the guidelines. And also that, at least in our country, we have had an easier task, I think, introducing candidates also at the more peripheral hospitals in our country. But I think it's important, of course, to recognize that you have to adopt the recommendation to your local setting, what is your prevalence and what is your local epidemiology. And I think it's very important that they will be constantly revised and that new data will be incorporated. So with that, I would like to thank you for your attention.